right, great, okay. Well, thank you very much. I'm so delighted to be here. And my grant, or our grant, has been funded more than 6, 7, 8 years by Spastic Paraplegia Foundation. So once again, I'm really grateful for your support. So today's title is Tackling PLS. Now I have been tackling with ALS for many years. I'm specializing in ALS, but PLS is such an important disease to understand entire motor neuron disease. Just we heard an excellent speech by Dr. Statland, and we need this kind of study more and more to treat this difficult disease. So today's topic is clinical trial readiness in PLS and also PLS FRS. I'm glad Dr. Statland explained ALS FRS, also SP ratings clinical scale, and also scientific conference on PLS. So those three are my topics. So PLS is a completely neglected disease until recently. I think this SPF changed really the world. I think PLS has not been really studied well, but the effort of SPF changed everything. So we have much more active, better studies. And PLS does not affect survival, as you know, but causes lifelong severe progressive motor dysfunction. And also, it has never been included in ALS clinical trials. Past 30 years, we had many, many clinical trials of ALS. ALS is indeed fatal, rapidly progressive disease, but PLS never been included. Quite frustrating. And also exceedingly rare and difficult to investigate. There have been only retrospective studies until recently, with 5 centers studied PLS retrospective. That means just look at the chart, what the patient showed, clinical symptoms, signs, and what other studies. Those are retrospective studies. But recently, neuropsychological studies has been done. A few studies done showing very important studies. Also neuroimaging, that means changes to upper motor neuron, MRI imaging change, also PET scan. Probably you may heard yesterday by Dr. Paganoni. And those studies are going on at Mass General and other groups, very important. Now we did 5 sites. Why 5 sites? Because 5 sites studied PLS retrospectively, so they are interested in. So we put together an SPF funded prospective clinical molecular studies. The paper was published a couple of years ago. We found very important findings in PLS. So it is time for more prospective studies and hopefully clinical trials. So clinical trials readiness in PLS. So this is a very attractive. When I saw this notice, wow, this is the grant I have to get for PLS, because PLS is the rarest motor neuron disease. If we see 100 ALS patients, we find probably few turns out to be PLS. ALS is said to be rare disease. ALS, I mean Lou Gehrig's disease, a rare disease. But PLS is much rare and exceeding rare. So we thought this is the way we have to get the grant. NIH grant is so important because they pay a good amount of money to do good studies, as just we heard from Dr. Statland. So we applied, and 2017, I hate to tell you, failure story, but failed, was not funded. So just resubmitted for a federal grant February 2018. Next month they will review, and I'm still hopeful, but as I understand, most grant funded is already treatment is there, just not quite ready to start that medication or particular treatment. So they suggested we do a little bit more natural history studies to find out the disease scales and so forth. So we may not be there yet, but still hopeful. So we are trying to start study 100 patients from very early stage and established patients. We improve diagnostic accuracy clinically and also molecular genetic studies, and improved biomarkers has been developed. Already we heard this morning how important to have very good biomarkers. And we have to have biomarkers to help to understand the clinical progressions. We have now lipid signatures. Lipid is probably, you know, brain has mostly lipid and the proteins. So lipid is very, very important. And so we have now signature very specific for Lou Gehrig's disease and PLS. And they seems to change with the time. And also skin fibroblast mitochondrial bioenergetics. We have been working with widely known scientist. His name is Giovanni Manfredi at Cornell. We developed skin fibroblast culture and mitochondrial dysfunctions. And PLS is far more significant compared to ALS. So we can separate between ALS and PLS. But change over time may not be great. And lipid signatures also change over time. This was done by our colleague, Estela Area Gomez. And so I think we have some biomarkers still early, emerging. And we have to prove those are really good ones. So also, as we heard, ALS-FRS, which is the standard most important scale for ALS. Now, we heard the specific scale for HSP, but we have to have a very specific scale for PLS. That's what we developed, the PLS-FRS, and I'll tell you this a little bit more detail. So also, natural history means how disease begins and how disease progress is so important, and that's what we have to learn. That's what we hoped we can do through this special grant. And also, PLS is ready for clinical trials in the future. We don't have any specific medication. The reason simply we don't know the mechanism is. So we have to know mechanism. We have to have better medication. Yet, if there is a medication for ALS, that medication might help PLS. We don't know. So that's what first step we can do. So those are just a list of centers we saw previously, but there are many centers here throughout the United States. And as you see, there is a list of patients they saw in 1 year, 4,176 altogether 1 year. Then they have 369 PLS patients. And those are not just early onset, but all together. And also 125 altogether early pure upper motor neuron disease, which may turn out to be partly ALS, may turn out to be PLS. We don't know, but they have those cases. So we have enough number of patients to work with. So why PLS functional rating scale is important? And so ALS-FRS, the most validated, widely used scale for ALS, just we heard by Dr. Stutland. And so ALS is rapidly progressive disease. And we see patient ALS every 3 months. And every 3 months, they change. Those who were walking 3 months ago, now not able to walk 3 months later. And kind of changes. That is a scale made for ALS-FRS-R. So average monthly 0.8 per month change. And we studied actually ALS Cosmos, which is an acronym, is a cohort study of multicenter oxidative stress. And that study seems to be much more moving fast. average 1.4 per month. However, we studied 5 centers, PLS Cosmos studies declined average, look at this number, 0.05, almost no change. Yes, changed over 2 years. We looked at the change, a significant change. But if we change so little using standard LSFRS, cannot be used for clinical trials. Clinical trials is short, effective studies. So we have to have a specific scale. That's what comes idea of a PLSFRS. So the LSFRS is not sensitive enough to detect significant changes. So we had a number of patients, we got together, we had ideas, we talked about what's important, what not, and so forth. We developed a prototype of a PLSFRS at the Columbia University, and then we studied. So development PLSFRS was funded by SPF again, and also Mr. David Marin and his family. So we are really once again grateful. So already we heard about LSFRS R. Original scale was developed in early 1990s. I was one of them, and then changed to LSFRS R. And this is a very, very standard scale. Any clinical trials for ALS, you cannot find any clinical trials without using this scale in ALS. So we added additional point, for example, speech and fine motor, gross motor. I'm not sure you can see it. I'm not expecting you to see it. Just point is, original scales is a 4, 0 to 1, and 0 to 4, excuse me, 4 is normal, 0 is nothing. And so 1 to 9, we added in between scale. So a little bit more finer tuning. And yeah, good idea, and seems to work. Well, I believe so, but you have to prove it. Reliability studies, what we did was you have to know when you develop a scale is good. If it's same result, if you ask the same question, different time, the same person, we call intra examiners scales has to be same, but not necessarily always same person can ask. If evaluator changes, inter raters scale should be same. Also, you have to develop this kind of scale. You have to call. If patient cannot come, you can call in and ask same question. So maybe telephone scale might give a different result. That's not good. So telephone is also should give the same result. And also telephone to telephone should be result. So this was kind of an ambitious plan, but we did baseline, 3 weeks, repeated within 3 weeks, and then 12 weeks and 24 weeks, and we have also 48 weeks. So scale change, no change with those baseline, but a change over time. So those telephone interview was done from Columbia University, and 12 weeks and 24 weeks. So this novel scale PLSFRS, a multi-center study, again, almost the same site. They are willing to help us working together as a partner for PLS, clinical trial readiness studies. And we enrolled 75 patients in over 6 months, which is very, very good. And also retest reliability studies. That means baseline 2-3 weeks, 44 only analyzed, already now 75 analyzed. This is a little bit early result. And also internal consistency and construct validity. That means internal consistency. Scale has 12. And some scale in one disease moves this way, and some scale subscale moves that way. And the scale moving so erratic, that's not a good scale. Generally, as a scale, basically same level of change and so forth. That's what called internal consistency. And also, when you develop scale, you have to validate with well-established and already known scale, they are moving the same way. That's what called construct validity. Again, also, you have to show a change over time. Scale is sensitive to demonstrate time, 12 weeks, 24 weeks, and 48 weeks, which is ongoing. And ALS-FRS is a 48 point. 48 is completely normal, and 0 is nothing. And the PLS-FRS is a 66 point because we put 2 scales in between except for pulmonary scale, subscale. Pulmonary subscale has 3 subscale, but we don't believe, based on previous studies, the pulmonary function deteriorate in these patients. So again, this just a list of sites we worked together, and about actually 21 centers. Some centers earlier study could not join us, so we recruited other centers. So those are 20 centers you see. Dr. Statland's University of Kansas is included, of course, and NINDS, and all those people are helping us to develop these studies. So internal consistency, as I said, the scales should be about the same, and different analytical method, the point is 761 or 0.763, essentially acceptable, good. 0.800 means excellent. 900 is almost identical. I'm not identical, it's so perfect, but we are quite acceptable result. And also we did construct validities looking at well-accepted neuro QOL was developed by NINDS, and also another scale is just a 10-point Schwab England scales based on ADL, Activity Daily Living, and we compared those known well-established scale moving with this disease, how this PLS-FRS moving against them. And in fact, p-values are so good, but range was about, for example, fine motor PLS-FRS against upper motor neuron function, 775, almost close to 8. It's very good. And also gross motor is 761. Again, acceptable range, but close to 800. And total is again, total scale is 716. Very good. So those are quite acceptable range. So we did a test-retest. If you change examiner, rater, or change to telephone and so forth, as you see, we looked at the 2 different ways, Pearson's agreement and also Kappa agreement. And for example, best one is surprisingly a primary evaluator when she or he call patient telephone, almost 0.93 Pearson's agreement, almost so good. But when you use Kappa agreement, less, and Kappa agreement might probably a little bit more difficult. But I think all study is acceptable, good to some extent range. So we are quite confident and pleased to say that we can use this PLS-FRS as a scale for ALS at this baseline. So we have to demonstrate those PLS-FRS changes over time. That's what we have been doing. And so this is a very, I must say, good scale to use. So change over time, I hope you can look at the scale. Point is, disease progress. So disease has to show progressions. So most important column is 95% confidence interval from the mean. So every number minus. Minus means disease deteriorating from baseline to going downhill. So greater the number, better. But the point is 95 confidence interval everything is negative. Even lower score is negative except respiratory. Respiratory, if you look at respiratory, fourth row, you can see respiratory subscale is 0.26 to 0.17. Some of them actually even getting a little bit better. So although I told you PLS patient does not change respiratory function, so that's okay with us, but all those other things going down. And total scale, you can see fifth row, PLS FRS total scales is change 3, and some patient went to less 16, that means 16 point lower. So you can see clearly deteriorating. So we are very, very confident. Even at the 24 weeks showed significant change, worsening disease scale. That means now we can use this scale. So our novel PLS FRS showed significant changes over time in bulbar, fine motor, and gross motor subscores, as well as total scores, not respiratory. But that's okay. And PLS FRS also revealed greater sensitivity to detect the changes in PLS compared to the ALS FRS. That's what we wanted. ALS FRS is so insensitive, but now we have fairly sensitive scale. Also, total PLS FRS score was significantly positively correlated with patient reported outcome, which is very important, PRO, how patient feels. That's called PRO, and this is NeuroQOL, upper extremity score, negatively correlated with, and also negatively correlated with CGIS. This is the clinical global impression of change. And this scale only asks question whether disease is the same compared to before or worsened, a lot worse, or a little bit better, a lot better. That's only 7 scale and 7 point. And so this one negatively correlate means PLS FRS going downhill, patient symptoms getting worse. But CGIC is going up means disease is showing worsening, and greater scale is worsening, and the minor scale is better, a little bit complicated, and the other way around, but perfectly fitting with CGIC. So I'm very happy with this result. So that the fact that the PLS FRS showed significant changes in a period as short as 24 weeks. I don't think we can do 24 weeks clinical trials in PLS. PLS is moving slow, but only even 24 weeks show the changes. So that's very encouraging. And we looked at the 2 years change with previous studies. So we can now shorten up at shortest as 1 year. 1 year probably good enough to do clinical trials if used as a primary outcome, and it can shorten future study period to perhaps 1 year. So clearly shifting to long 2 years to 1 year. So clinical trial readiness project in PLS that we proposed will confirm such possibilities. We have to repeat in real patient population once again how they do it, and so that's what we hope we can do. But again, I have to admit, when I come back next year, I have to say bad news, but again, we're still hopeful. So PLS FRS 1 year follow-up. So we get probably towards the end of December to early January, we finish 1 year follow-up, and we completely analyze. We send the abstract to Motor Neuron Symposium, so we can show 1 year result and then future. So we are really hopeful that we develop the PLS FRS in very standard way. So utility of the PLS FRS, how important is, because the future clinical trials we can use this scale in PLS, and also clinical research in PLS. many studies done in ALS research, and they use ALS FRS as a patient condition and so forth. We can use, when you study PLS, we can use this scale. Also, even you can use PLS FRS in clinical setting, and we see patient ALS and PLS all together because of motor neuron disease, but scale-wise, you can use this specific scale to follow the patient. And we need to explore the possibility of increasing sensitivity to detect the changes in ALS for a shorter period of time in future ALS clinical trials. Most ALS clinical trials done, minimum of 12 months, longer was 18 months to show survival change, and even ALS-FRS 9 months, 12 months. But it is possible if you use this scale, maybe even shorter period. And currently, some of you know, edaravone has been approved for the treatment of ALS by FDA. That study is only 6 months, which is unheard of, such a short period. But if you use this kind of scale, even possible to shorten up a study period. So where does the PLS stand at present? I have to admit, maybe I'm too exaggerating, but PLS is an exceedingly rare, mysterious, and enigmatic disease of no cure, and has been a neglected disease in general. I must say this is true. And there have been very limited studies to date, partly due to the reality of disease and the shortage of a participant. We need a greater number of patients to study. As clinicians, we are told that we have to wait at least 3 years after symptom onset before diagnosis of PLS can be made. Anyone here with a PLS, I'm sure you are told by neurologist, early stage, we cannot make diagnosis. You have to wait 3 or 4 years. Have you ever experienced that? So what does it mean? You have to wait 3 years or 4 years? So that's not totally acceptable. We have to deal with early stage of the disease. We don't know whether early PLS or early ALS. We just don't know. That's what we have to work on. So how we can change this frustrating reality? And we should stimulate and encourage more research in PLS. One way to hold, I think, is highly scientific international conference PLS. I realized because of my experience, I sent the grant, I worked day and night to write the grant. The writing the NIH grant is not easy. There are lots involved. So we send out, and then 4 months and later, sorry, you fail. So such a discouraging things, but I sensed maybe we are not there yet. So before they tell me again, you are not there yet, I think we have to do more studies, more stimulate investigators, scientists. We have to work with the PLS. So that's the reason I wanted to have a conference. We have to make PLS a top priority of motor neuron disease research and clinical trials. Research in PLS would improve the understanding of ALS and motor neuron disease in general. That's what Dr. Statland's group doing it, motor neuron disease, many different motor neuron disease, to understand the disease, natural histories, biomarkers. That's what we have to do in same way, more PLS. So PLS International Scientific Conference, we planned 2019, and we get mostly United States, but from outside of the United States. The expert is limited, but surprisingly you should know most everyone is expert also in ALS. So we have to push this field forward. The organizing committee consists of, I'm sure you know, Dr. Tassi, Dr. Elman, Dr. Flota, Dr. Paganonis, and Siddiq and myself. They are all interested in PLS. Dr. Tassi and Dr. Paganoni doing a lot of neuroimaging studies. Dr. Ellerman developed upper motor neuron scale. Dr. Flotta is probably the doctor who saw largest number of PLS at NINDS. And also Dr. Siddiq is earlier, he found second gene of ALS, alsin, for juvenile PLS. And I am clinician working with this PLS. So composition of speakers, moderator, 25 domestic and 11 international. So we are asking again NINDS to support this conference. It is tough. They will give only tiny drop of money, but if this peer-reviewed R13 conference grant is approved, that means scientific level is already very high. That's what we wanted. Also, National Center for Advanced Translational Science, NIH Development Office of Rare Disorders Research also asked to fund. And SPF, of course, they already gave some letter. Thank you for Mr. Frank and letter to support this conference. Really, I'm grateful. I'm still working on other companies to support. It's costly, but I think it's worthwhile. And we will review several PLS topics, for example, clinical spectrum. And Dr. Fink is coming next year to tell what is not SPF. We are talking about the PLS. And so clinically, what's the difference? What's the difference from between ALS and PLS? And sort of things we have to define clinical features. Cognitive function is clearly involved in some of the PLS patients. So why? That's what we're going to look at, the cognitive function. Electrophysiology important. To make diagnosis, you have to do EMG, but also upper motor neuron sign, transcranial magnetic stimulations, electrophysiological investigations is important. And neuroimaging, already we spoke several times, important. Genetics. Genetics, eventually, most of neurogenetic disease turns out to be genetic. Not just one gene, but multiple genes, susceptible. I was born to susceptible certain things, certain disease. If you find 2 or 3 or more gene meet in your body, might invite such disease. So we have to have very detailed genetic investigations. Neuropathology, it's rare to have a pathology in this disease, but neuropathologists coming and give key talk. And also biology, biomarkers is important. How we can use outcome measures, PLSFR is one of them, and how we can measure, quantitate progression of disease. And also talking about the clinical trials in PLS. After me, Dr. Dale Lang is going to talk about his studies and the symptomatic treatment. I think we are coming to think about clinical trials in PLS. Again, also diagnosis. We have to do something with early stage. Just unacceptable to say, well, we cannot make diagnosis, sorry, you have to wait 3 years or 4 years. How you feel. So also was never included in ALS clinical trials. So we have to do something about the diagnostic criteria. Also, already we have registries. And Niels has, Dr. Paganoni has PLS registries. But we have to work internationally, and we need more larger number of patients to work with. So we will have next year, right before American Academy of Neurology meeting, believe it or not, this will be Philadelphia, and so to save some air cost, we're going to have right before this meeting, so someone has to come to AAN. We don't have to pay airfares. So that's what we plan, and certainly welcome anyone who'd like to come to this meeting, you're welcome. And so I show you how we are funded, and SPF is really champion to support the PLS study we have been doing, and NIEHS is funding partly PLS Cosmos study, but mainly ALS Cosmos studies, and NINDS is always supportive. MDA unfortunately decided not to support the PLS sometime last year. I don't know why, but they have been supporting a lot of other studies, particularly MDA wing studies. So I think it's funding agencies again very important. But at the same time, we have a scientist working with me. Again, as I said, I'm a clinician, and I know how to see patients and deal with making diagnosis. But the scientific endeavors really needed to collaborate and help with super scientists with Columbia University and outside of Columbia University helping this project. So what I'm saying is not just my result, but the entire our group's presentation. So thank you very much.